Assalamu alaikum. Today I'm going to read AKP clinical case number 18, that is, a child with immunodeficiency and hemoptysis. This case involves a 9-year-old girl with hyper IgE syndrome presenting with a 6-month history of a tickly cough, sometimes productive of clear sputum, and 2 episodes of hemoptysis in the past 24 hours. Her history includes a neck abscess, recurrent oral thrush, and right upper lobe staphylococcal pneumonia during infancy. This resulted in a persistent nematocele, a known complication of hyper IgE syndrome. The girl has been on prophylactic cotrimoxazole since the diagnosis and had remained stable until this presentation. Examination findings are she is afebrile, in no respiratory distress, with a central trachea. Decreased air entry is noted over the right upper lobe. Chest X-ray findings evidence of a cavity in the right upper lobe with solid material consistent with a fungal ball. The patient's history of hyper IgE syndrome with persistent nematoceles, cough with hemoptysis, and radiological findings of a fungal ball strongly points to aspergilloma. Aspergilloma, this is a form of aspergillosis specific to colonization of pre-existing cavities, for example, nematocele or TB cavity, not an invasive or allergic process. These fungal balls are composed of hyphae, fibrin, and cellular debris, leading to irritation and minor bleeding. So first question asked in this case is, what is the most appropriate management here? Select one answer only. Let's rule out one by one. Option number 1, flucloxacillin and clindamycin for 4 weeks. These antibiotics are used for bacterial infections such as staphylococcal pneumonia or abscess. While the patient had staphylococcal pneumonia in infancy, this is a resolved issue, and the current problem is fungal. Persistent nematocele in hyper IgE syndrome are not resolved by antibiotics as they are structural abnormalities. So this is the wrong option. Next is rifampicin, isoniazid, pyrazinamide, and ethambutol. This regime is for tuberculosis treatment. TB is uncommon in hyper IgE syndrome and typically affect the lung tissue, not pre-existing cavities like a nematocele. Additionally, there are no systemic symptoms like fever, weight loss, night sweats, or radiological signs suggestive of TB in this case. So this is also wrong. So next option is itraconazole. Itraconazole is an antifungal agent used for conditions like invasive aspergillosis or allergic bronchopulmonary aspergillosis. Next option is diagnostic aspiration of the lesion. Aspiration of lesion here is unnecessary. Aspiration process is a risk of bleeding, particularly in a lesion prone to hemoptysis. So it is not suitable here. So the right upper lobectomy is the most appropriate management in this case because the patient has symptomatic aspergilloma in a pre-existing cavity like nematocele in her right upper lobe, causing hemoptysis. Hemoptysis, which can range from mild to life-threatening, occurs due to erosion of blood vessels by the fungal ball. Since aspergillomas in hyper IgE syndrome are persistent and antifungal treatment is rarely effective, surgery is the only definitive solution. Here is the second question. What is the likely cause of the recent problem? Select one answer only. Let's rule out other options one by one. Candida infection. Candida infection usually causes mucocutaneous infections, for example, oral thrush, esophagitis, rather than pulmonary disease. Invasive pulmonary candidiasis is rare and generally occurs in severely immunocompromised patients. This patient has no systemic symptoms or risk factors for invasive candidiasis. Next option is invasive aspergillosis. Invasive aspergillosis is a severe, rapidly progressing disease seen in profoundly immunocompromised patients, such as those with neutropenia, bone marrow transplant, or prolonged corticosteroid use. It presents with fever, severe pneumonia, and systemic illness, which are not present in this case. So it's wrong. Next option is non-tuberculous mycobacterial infection. It is caused by Mycobacterium avium complex, typically occurs in bronchiectatic lungs, not in isolated cavities like nematocele. Non-tuberous mycobacterial infections causes chronic cough, sputum production, and weight loss, but they are not typically associated with fungal balls or hemoptysis. Next option is staphylococcal infection. Staphylococcal infections are typically acute severe bacterial infections that present with fever, consolidation, and systemic symptoms. While this patient had staphylococcal pneumonia in infancy, it was treated and resolved, leaving behind a nematocele. So aspergilloma is the correct answer because the patient has a history of hyper IgE syndrome, which predisposes her to persistent nematocele, providing an ideal environment for aspergillus colonization. Her symptoms, including hemoptysis, are classic for aspergilloma, as the fungal ball irritates and erodes nearby blood vessels. Radiological evidence further supports this diagnosis, showing mobile mass within the cavity, a hallmark feature of the aspergilloma. This condition aligns with her immune status, history, and imaging findings, making the most likely cause of her recent symptoms. This is all about from this case. If you have any question, comment below. Like, subscribe, and share. Thank you for watching.